Hello, good morning. We are welcoming you and happy to be together today. I think you can start to share your screen and we can start the presentation. I think we have a meeting last week, which was very interesting, which covers mainly the introduction and the instrumentation, accessories that required for flexible ureteroscopy. And the second presentation was covering the tips and the tricks and the techniques of flexible ureteroscopy. We are here today to listen to the difficult cases, the challenging cases, and the complication that we may face during flexible ureteroscopy, and how to avoid and how to diagnose and how to manage. So welcome, and we can start. We are listening.
Professor Yasek, and I will start my video. Okay. Can you see the PowerPoint?
ستينات لما طلعنا
بيضاء.
والله 30 ولا يعني انا طلعت جيت لما نورت
Can we mute our computer, please?
Yes, we are working on it. Just wait
Okay.
for 5 seconds.
我说话有声音吗？好，开始啊。Okay. Good morning, everyone. My name is Wang Ming Chao, and I come from the Department of Urology, SRRSH Hospital. So now I'm a fellowship, and I graduated from the Zhejiang University. Today I will talk about the complications of the flexible ureteroscopy with lithotripsy. We will talk about from 3 aspects: the prevention and the recognition and the management. As modern ureteroscopes have become smaller and less traumatic, and as safer intracorporeal lithotripters have become widely available, and also as a better understanding of the technique principles of ureteroscopy has been developed. Now the number of complications arising from the management of ureter stones have been steadily decreasing.
Dr. Wang, sorry for interruption. Can you little bit raise your voice or make the mic closer?
Okay.
Yeah.
With the recent advances in endoscopic and hormone laser technology. Now okay? Dr. Yasser?
Yes, better.
Okay. With the recent advances in endoscopic and hormone laser technology, the flexible ureteroscopy and laser lithotripsy has become more and more popular, even to treat large renal stones, because it decreases morbidity and hospital stay with a stone-free rate similar to that of the PCN. But The reference still reported an overall complication rate of 3.5%. The data come from a study of 11,885 FURS procedures. Fortunately, most of the complications caused by urethral stones and their management respond favorable to simple drainage of urine with urethral catheters or stents. But unfortunately, although some complications were to happen, but it will be severe, even life-threatening. So what is our attitude to the flexible ureteroscopy laryngectomy? I think it should be, don't be afraid, but we should pay attention, especially to the complications. Okay, let's start with the first case. It's a 65-year-old male patient. He complained about the gross anterior and frequent bilateral flank pain bothered him for 6 years. We gave him an abdominal CT scan and some routine blood tests and urine tests. And then we confirmed the diagnosis of bilateral renal stones. So finally, we suggested him to flexible ureteroscopy filming laser lithotripsy for the right renal stone and proceeded. So here is his preoperative CT scan. We can see the calculi located in bilateral renal pelvis and the calyces. And the stone in the right kidney is larger, about 1.5 centimeter, and there is no obvious hydronephrosis. But the surgery, unfortunately, the surgery didn't go smoothly. The surgeon was a freshman, and he made a mistake when he placed the urethral sheath. He forced the obturator into the renal parenchyma and then caused the renal bleeding. The surgery field was full of red, and he cannot see clearly, even increases perfusion pressure. But fortunately, after some management deal with by other experienced surgeons, the bleeding stopped, and then the lithotripsy still finished. But the patient still had a more moderate hematuria post-operatively, and proceeded continuous blood irrigation for 3 days. And here is the post-operative CT scan. We can see the blood clot in the right renal pelvis and the right ureter. So now let's discuss about this complication. We call the intraoperative hemorrhage. Usually means kidney bleeding during the procedure of operation. The reference reported the incidence is 2.3%, and the data from our center is 1.6%. Usually it is caused by the injury of renal parenchyma or pelvic mucosa during the procedure of sheath placement, just like the case we discussed before. Sometimes injure the renal pelvic mucosa or the neck of calyx when we do lithotripsy and holding laser. If we injure the renal pelvic mucosa, usually the bleeding is moderate. But if we injure the neck of calyx, usually the bleeding will be severe. So we should take care when we do the hernia laser. So the problem is how to prevent this complication. First, I think choose a sheath with the right length according to the gender and height of the patient. Because the injury of parenchyma, pelvic mucosa during the procedure of sheath placement, is the major cause of intraoperative hemorrhage, and a suitable sheath will help us, I think. If the length of the sheath is not enough to penetrate the renal carotid, it will fail. And in our center, we usually prepare two kinds of sheath in our operation room. The short one is for the female patient, and the long one is usually for the male patients. And secondly, we should always make sure that the safety guideline is in position, and if the guideline can circulate in the renal pelvis, it's the best. With the guide of the guideline, the sheath is hard to injure the renal parenchyma. Of course, if the surgeon places the sheath violently, the injury will still happen. So we should take the sheath advance through the ureter slowly and smoothly, and don't violently force the sheath advancing when we encountering resistance. We need to retrieve the obturator and take the practical ureteroscopy into the sheath and observe the circumstance of the ureter and make clear that why we encounter resistance. That will help us to make a right decision and avoid the injury. And next, when we do light strips by the Holman laser, clear vision is important for the prevention of the injury. Fluent circulation of sealing and suitable perfusion pressure is the key factor for clear vision. Then we should avoid to injure renal pelvic mucosa, especially the neck of the calyx. And sometimes the patient's breath will make the kidney up and down regularly, and this situation will increase the incidence of injury and we do Holman laser. So we should follow the rhythm of the breath, and of course we also can ask the anesthetist to reduce the breathing rate if the patient is in general anesthesia and the breath is controlled by the ventilator. Then we talk about the management. If intraoperative hemorrhage happens, if the bleeding is mild and we still have a good vision of the surgical field, the light strips can still go on. Otherwise, suspend the surgery and wait. Usually, we will seal the sheath with the obturator and wait. It will help the blood coagulate and blood clot, maybe make a pressure to the injured tissue and help the tissue to stop bleeding. Usually 10 to 15 minutes is enough. Then we observe the circumstance of renal pelvis with a flexible ureteroscope aid. If the bleeding stops, the surgery can go on. Otherwise, stop operation within the welding as ureter stents is a reasonable position. In the case talked about before, we just wait for 10 minutes, then the bleeding stop. So we will still finish the light strips. So very lucky. And lastly, irrigate pelvis with high sealing is also one of the measures, but not regularly. Okay. Monitors hemoglobin, and the coagulation function post-operative is important because bleeding may be continued post-operative, just like our case mentioned before. The patient still had a moderate anterior post-operative and proceed continuous blood irrigation for 3 days. Always, the post-operative bleeding will not be severe, and with the drainage and continuous blood irrigation, it will stop spontaneously. Use of antibiotic post-operative is necessary because bleeding may be induced the infection. So this is we talk about the complication of intraoperative hemorrhage. And then we take a look at another case. It's a 60 years old.
Do you prefer to have to collect if any questions about this case, or keep the questions at the end? What do you prefer? Can you hear me? I'm just asking, do you like to have discussion from our colleagues case by case, or to keep the discussion at the end?
I think the end is better.
Okay, that's fine.
Okay, thank you. Okay, and now we take a look at another case. It's a 17 years old male patient. He discovered the right urethral stone one week ago during the routine physical examination. And we gave him an abdominal CT scan and some routine blood test and urine test. Then we confirmed the diagnosis of right urethral stone. Here is preoperative CT scan. It has a severe hydronephrosis in the right kidney, and the parenchyma of the right kidney is atrophic, and also have the dilated ureter. Sorry, I forgot the picture which showed the stone. The stone is about 1.5 centimeters, and it's in the proximal of the ureter, located on the proximal ureter. So finally, the patient proceeded a flexible ureteroscopy, hormone laser, lithotripsy for the right urethral stone. The procedure went very well and very successfully. And the operation time is 1 hour, a little bit long because the stone is large and compact, and it's also adhered to the urethral mucosa tightly. But 10 hours after surgery, the blood pressure dropped to 8/56 with the increased heart rate, and the vital signs showed that the temperature is okay. It's 36.5, and the respiratory rate is 18, and the heart rate is a little quick, 98 BPM, and the blood pressure is 8/56. and the patient is in a condition of a shock. So we then activated anti-shock therapy immediately, such as fluid infusion, oxygen uptake, and so on. And then the vital signs stabilized. We also took a blood test immediately. Here we can see that the preoperative hemoglobin is 103 grams per liter, and the post-operative hemoglobin is 68, and blood leukocyte is 5.5 preoperative, and the post-operative is 7.8, and CRP preoperative is 2.2, and post-operative is 6.5. And the PCT is also normal, preoperative and post-operative. And the post-operative time, preoperative is normal, it's 13 seconds, and the post-operative is 70.6 seconds per lung. And the fibrinogen preoperative is normal, it's 3.44, and post-operative it's decreased to 1.14. And then we give him an abdominal CT scan. A perinephral hematoma was discovered from the CT scan. You can see here a huge hematoma in the retroperitoneum, and the perinephral hematoma spreads the renal pelvis, so the double J stand went down along the ureter. So this case give us another severe complication called post-operative perinephric hematoma. The reference reported that the incidence is 0.77%, and the rate from our center is 0.8%. Why perforation can cause perinephric hematoma, and this situation is just similar to the previous case when we talk about the intraoperative hemorrhage. If she penetrated the parenchyma deeply, and the post-operative perinephric hematoma may occur. Then the long-time high pressure irrigation and intravenous parenchyma are the risk factors for the complications of post-operative perinephric hematoma. In our case, the patient had a severe hydronephrosis and atrophic renal parenchyma, and because the stone is large and compact and also adhere to the ureter mucosa tightly, so the operation lasted for 1 hour. And also because the stone adheres to the ureter mucosa tightly, so when we pump saline through the flexible ureteroscopy, the saline can enter into the renal pelvis relatively easily, but it's hard to circulate back to the sheath. So the result is the renal pelvis maintained a high pressure for a long time. And sometimes we will encounter the catechal stones. Usually the catechal neck stenosis is combined in these cases. The diameter of the stenosis catechal neck can just contain flexible ureteroscopy. With long-time lithotripsy, calyx maintained high pressure and also will cause the post-operative paranephric hematoma. Occasionally, the post-operative paranephric hematoma is also called by the fourth retrograde pyelogram. And the post-operative paranephric hematoma also has its own features. To understand these features, it will help us to recognize this complication as early as possible. Exception for the sheath injury, usually there is no intraoperative hemorrhage and the surgical field is always clear. And usually there is also no severe hematuria post-operative because it's a paranephric hematoma. If the renal pelvis mucosa is intact and the hematoma will not cause the hematuria, it's located on the retroperitoneum. And sometimes there's non-coagulated blood in the abdominal cavity or the thoracic cavity. These non-coagulated blood are infiltrated through the peritoneum and the fluid. Sometimes the hemothorax will influence the respiratory, and a thoracic drainage is needed. And lastly, the ultrasound and the CT scan can identify the paranephric hematoma. So if we encounter a hemorrhage shock patient after the physical
Dr. Wang, we cannot hear you. Elvi, are you there? Anyone can hear us?
Yes, I can.
Yeah.
Yes, I can hear you.
But Dr. Wang is not.
I will check with him. Just wait
Yes,
a
please.
second. He might be lost.
Okay.
Okay, now we can. Okay, Dr. Yash, can you see
Yes, we can hear you now.
Okay. And you also can see the PowerPoint?
Yes.
Okay, sorry for the interruption. Okay, let's continue. So if we encounter a hemorrhagic shock patient after the flexible ureteroscopy, and abdominal and chest CT is necessary, and if not, maybe the paranephric hematoma will be omitted. So, and it's a life-threatening complication. So we cannot omit this complication if it occurs. To prevent these complications, I think we should try our best to keep the intrapelvic pressure during the operation. If it cannot be succeeded, a secondary operation with the drainage by a ureteral stent is a reasonable decision. Secondly, controlled operation time is also important. And similarly, secondary operation is not a bad choice for the patient and also for our surgeon. If the postoperative perinephric hematoma occurred unfortunately, prolonged bed rest is necessary. But I think it don't need the definite bed rest, and I think the 7 days is at least. Then also, of course, to monitor the vital signs, hemoglobin, and coagulation function carefully and consistently. Tendency is important. If the hemoglobin stays stable, even not increased, it always means that the bleeding has stopped and a further interfere is not necessary. And if the hemoglobin goes down obviously, transfusion is necessary. The coagulation function is also important during the progression. Usually, coagulation function will be abnormal because of bleeding consume a lot of thrombin and fibrinogen, and the abnormal coagulation function will cause more bleeding. It becomes a vicious circle. So the giving of plasma fibrinogen is important to reverse this vicious circle and help hemostasis. Because the perinephric hematoma may be induced the infection of enriched peritoneum, the use of antibiotics is necessary. And if the conservative treatment didn't succeed, the selective embolization under the DSA is necessary. It's a mature therapy and also is the best option for the patient. And the open surgery should be avoided, I think, because actually the surgery cannot deal with the hematoma except of the nephrectomy. On the beginning of my career being a urologist, I heard two tragic stories. One story is a 38-year-old female patient who underwent the lateral flexible ureteroscopy lithotripsy, and she died 4 days after surgery. Another is a 52-year-old male patient who underwent bilateral FURS, survived in ICU relied to the ventilator. And these two cases occurred respectively in two large medical centers in our city. And then I realized that the flexible ureteroscopy lithotripsy is more dangerous than what I imagined. And they are caused by a common life-threatening complication, post-operative uroseptic shock. The reference reported that the incidence is about 0.25%, and the data from our center is 0.50%. It's usually the upper urinary cannula will cause obstruction of the upper urinary tract, and in most of the cases, infection occurs. And the common bacteria is gram-negative bacilli, and the bacteria-induced the uroseptic shock are usually the ESBL positive gram-negative bacilli. And the flexible ureteroscopy has its own defect, perfusion pressure. The perfusion pressure usually causes a high pelvic calcium pressure. If the operation time is long. It will cause a long time high pelvic calcium pressure. The ESBL positive gram negative acid infection and the long time high pelvic calcium pressure are the two key factors induced the uroseptic shock post-operative. The gram negative bacilla has its own feature. It has the endotoxin in its body. When the bacilla goes into our blood system, our defenders will battle with the bacteria and kill the bacteria. But when we kill the bacteria, the endotoxin it has will come out and give our body a further strike, even we have killed the bacteria. And this strike will be more fatal. So, how to prevent this fatal complication? Firstly, urine analysis and urine culture should be tested routine, and then effectively control the infection perioperatively. And use antibiotics with ESBL enzyme inhibitors is a bad option. For the patient with severe infection, antibiotics that is not enough to control the infection. Preoperative drainage is necessary. Give a reminder, drainage is always the best therapy for the infection caused by the urinary obstruction. Also, routinely place a urethral stent 10 to 14 days before the posterior ureteroscopy lithotripsy is a good plan to reduce the incidence of uroseptic shock. And use the sheath routine during the procedure will lower the pelvis calcium pressure to reduce the incidence of uroseptic shock. And lastly, we should try to be rational and control the operation time. To tell the truth, some of our surgeons will be obsessed with lithotripsy, especially when he encounters a large stone. He always wants to do everything in one time. Even the operation time will last 3 to 4 hours. So in our center, we will cease the operation in
Dr. Wang, again, the connection is not working well. Can you hear me? We cannot hear you, Dr. Wang. Elvi, can you check?
Yes, I will. I saw that his connection is still here.
Yes, welcome back.
come back. Okay.
Yeah.
Okay. If the uroseptic shock occurred unfortunately, I think we should immediately enlarge the blood capacity and use vascular active medicine and use the glucocorticoid to prevent the microcirculation disturbance and prevent DIC. And if the patient needs a ventilator support or the continuous renal replacement therapies, we should supply. But these are the management for the ICU doctors, I think. So what's the management for our urologist? I think maybe we can call an emergency consultation, and maybe then we can send the patient to the ICU. And that's what we can do only. Is it true? I don't think so. Or we can consider how to early recognize these complications and how to early interfere and reverse the septic shock. And this actually what we do in our team. And next, we will introduce another case. It's a female patient, 57 years old, and she complained about the frequent gross hematuria for 1 year. And the diagnosis is clear: left renal stone with left-handed fURS. And the CT scan showed that multiple left renal stones with left-handed fURS. The CT value of the stones is about 600 to 900 Hughes field unit. And then we can see the CT scan. There's handed fURS in the left renal pelvis, and the stone is large. And the urinalysis, the white blood cell is 50 per field, and the red blood cell is 15 per field, and nitrate is +2. The urine culture and the drug sensitive result is showed that it had infection caused by the E. coli, and that it's also the ESBL positive E. coli, and it's sensitive to the piperacillin tazobactam. And the blood routine is hemoglobin is 115 grams per liter, and the white blood cell is 5.4, and the CRP is 2.2. The renal function and the liver function is normal. A preoperative is we give him an antibiotic therapy is piperacillin tazobactam 4.5 gram intravenous with drip Q8 hours for 5 days. And then he underwent the left flexible urethral stent lithotripsy. The operation time is 1 hour. And even we use the antibiotics preoperative, and also it's the sensitive antibiotics to the E. coli. The septic shock still occurs 5 hours after the surgery. The vital sign showed that the heart rate is 110 BPM. 有问题吗？ And the blood pressure is 78 over 60 over 46, and the respiratory rate is 23 per minute. And the urine volume is low; it's just 17 microliter. And the ICU monitoring, and he lived in ICU monitoring for 18 days with a ventilator support and CRT, continuous renal replacement therapies. And fortunately, this patient recovered and discharged from the hospital 25 days after surgery. And this is the tendency of the white blood cell for this patient. And the white blood cell, we noticed that the white blood cell dropped to 1.2 at the time of 2 hours after after surgery. It's very low. And during that time, the CRP didn't change until 10 hours after surgery. So this information promotes our research about the receptive shock. In our research, we first established an animal model. It's the New Zealand rabbits for the receptive shock. All rabbits were anesthetized and intravenously for conditions and 5 to 10 microliters.
Excuse me, Dr. Wang, can you raise your voice again, please? And I ask Elvi to mute other audience because there are a lot of noise.
Okay. Hyperthermia was performed and the distal segment of the urethra was identified and ligated. The proximal segment was cannulated with a 4-branch catheter through a ureterotomy incision, and the catheter was advanced to the renal pelvis. And then we injured the E. coli with different concentration and injected the saline for the control group. Then we monitored the heart rate, arterial pressure, the mean arterial pressure, and oxyhemoglobin saturation of the rabbit. This rabbit model was stable. Stably had a uroreceptive shock, and then we tested the blood of the rabbit. And 2 hours after renal pelvic injection of the coli solution, we noted a statistically significant decrease from pre-operative values in the white blood cell. And in our multiple center research, include 12,500 patients who underwent upper urinary tract endoscopic left trypsin. And in 52 patients of them occurred the post-operative uroreceptive shock. We found that in the 48 patients with uroreceptive shock, mean white blood cell within 2 hours post-operative was 1.8. This was statistically significant compared to the pre-operative. But the CRP value showed no significant increase or decrease 2 hours post-operative, but it had increased significantly by the time of 12 hours after the surgery. And we analyzed the predictive value of the white blood cell 2 hours post-operative in patients with uroreceptive shock using an ROC curve. The ROC curve, the AUC was 0.983, indicating that the patient's white blood cell 2 hours post-operative was predictive of uroreceptive shock. And we further determined that at a white blood cell threshold of 2.85, the sensitivity is 95.94%, and the specificity is 92.7%. could be achieved for the diagnosis of uroseptic shock, and the Jordan value is 0.887. So the conclusion is a white blood cell of 2.85 or less within 2 hours post-operative might be a simple, effective predictor of uroseptic shock after urinary tract endoscopic lithotripsy, and in patients with high risk for uroseptic shock, the white blood cells should be measured intraoperatively and or within 2 hours post-operative. So that's the suggestion. And this research was published on the Journal of Urology, the best journal for in the area of urology. And our team did another research for the early interfere. If the early interfere can reverse the uroseptic shock, and the conclusion is early intervention based on the white blood cell measured within 2 hours post-operative could not only ameliorate the clinical cost, but might also avert the uroseptic shock induced by the upper urinary tract endoscopic lithotripsy. And when a drastic decrease in the white blood cell occurs, early intervention should be considered. And this research published on the Journal of Inflammation. And next, lastly, we'll talk about other mild to moderate complications after the first. The fever is the most complications occurred after the surgery, for this surgery. And but fortunately, most of the post-operative fevers respond favorably to simple drainage of urine and antibiotics using. And if the fever didn't recover, the gram-positive bacteria, I think, should not be admitted, because sometimes the gram-positive bacteria will also induce the fever after the first surgery. And for the ureter injury, it always caused by the injury during the procedure of sheath placement. You can see the figure. The first figure showed the G1 injury. It's the ureter mucosal injury. And the second, moderate, it's injured the muscular layer. And the third image showed that the sheath may be perforated the ureter and got the perforation injury. And for this ureter injury, always long-time double-distance injury will help curing most of the injury. And the rest of the injury cannot be cured. It will develop to the ureter stricture. For this part, for time reason, I just take it for the ureter stricture. I think usually we use the balloon dilation. It's a regular therapy, and then we wearing one double J stand or two double J stand. And if the dilation cannot cure the ureter structure, the urate plastic should be used for the patient. And in our center, we have developed the robotic assisted laparoscopy, the dual convulsive replacement for the uretroplasty. So, lastly, I summarize for the complications of the FURS. The FURS is still the most safe operation. Deal with the upper urinary cancer, and the ureteroscopic stone removal is highly effective, and most of the complications is mild to moderate, and overall it has a low risk of complications. So I still give my attitude to this surgery. Don't be afraid, but pay attention. So that's all. Thanks.
Thank you, Dr. Wang. It's very interesting to share with us your experience, and it's really very impressive and interesting research study that has been published in the Journal of Urology, and I think this has a value to keep in mind the parameters of prediction of septic shock and the improvement. If you allow me, we can open the discussion for the cases that you had. I can summarize that we discussed the case about intraoperative hemorrhage, and second case of post-operative perinephric collection or hematoma, and the third one is the septic shock. So, Elvi, if you can unmute our colleagues in Libya to see if they have some questions about the cases. Dr. Naji and our friends in Libya, any questions or any comment?
Yes, thank you, Dr. Wang. Professor Farahat, I have a few questions for Professor Wang.
Yeah,
regarding
the
first case, what's the place of the pre-ureteroscope fluoroscopy? Just to know the anatomical details of the pelvic calyceal system and the ureters. Does it help, or it does you need, or he need not to do it? Fluoroscopy. What I mean, contrast study before
yes.
before starting the procedure. The other thing, he talked about the length of the sheet. In what basis? Is it the gender only? We have some female which is tall, like the male patient. They use a shorter for female. Is there any another bias in this selection?
Okay.
The length of the sheet, because he just make it fix it short for female and long for male.
Yeah,
this
clear.
is the other. Regarding the clots. Once there is a bleeding and a clot, and he has to wait, as he mentioned, could we proceed if the bleeding stop, and or just we stent and we come back after 2 weeks, or we can remove if there is a small bleeding and clot, and then we can proceed if the bleeding stop. Okay.
Regarding, so let's to go one by one, because many questions we can forget. So let's to answer one by one. Dr. Wang, can you? I will come back to you again. But Dr. Wang, do you prefer to have a retrograde intrarenal biologography before to start, to this give you more idea about the anatomy, the position of the stone, the any complexity of the pelvic calyceal system, or it's not a routine work? Can I repeat again?
Can you slowly again?
Okay, so the question is, what is the rule or the importance of doing retrograde intrarenal bielography that help to identify the anatomy of the kidney before start the flexible ureteroscopy? To inject the contrast material before.
Contrast material, you mean?
Yeah.
In our center, we don't proceed the pylgram by the contrast material.
Okay. Actually, I will share our experience in that. We are not using the contrast material routinely in all cases, but yes, sometimes we do that if we have expecting complex renal anatomy or we have multiple stones and we cannot figure out some narrow calyces. So retrograde bielography can be helpful, but it is not a routine procedure. The second question, they asking about the length of axis sheath. Are you using length? Yeah.
The length of the sheath, you mean?
Yes. Do you prefer 35 or 45? You use it in all patients, either male or female, or
okay. The short one is 35 centimeters, and we use it for the female patients. And the long one is about, I remember it's 45 centimeters, and we use it routinely for the male patients.
So you fix the short one for female and long one for male?
Yeah, the longer one. But if the female is very tall, we will consider for the long one, the long sheath.
Okay. It has any significance to go for short or long?
Any significance? Yes. I think and second, maybe if we know the sheet is short, if we use the longer one for the female patients, occasionally some surgeon will, some freshmen will penetrate the parenchyma by the obturator. So we just make sure that we don't make a mistake of the length. But you mean this difference is significant? I think for the female, if we use the long sheath and the sheath left outside is very long, it's not convenient for our surgery procedure.
So let me to comment about this point. I think the story of the axis sheath, the main concern is the diameter, not the length. For the length, it's a matter of convenience of the surgeon. And the main concept of the length that you have to keep it below, few centimeters below the uretropelvic junction. This allow the flexible scope to can be manipulated freely, not to affect the deflection of the scope. At the same time, it will give a good irrigation and the backflow of the water. Whatever convenient with the surgeon, if he is using the short or long one, it's a matter of convenience. But the main rule and the criteria to have it below the pelvic ureteric junction and to allow the deflection. This is the main concern for the length. One more question, which is about if you have intraoperative bleeding and there are some clots. Are you planning to remove these clots to clear the field and then proceed, or you will stop and come back after a couple of weeks?
You mean if the bleeding, we don't have a clear vision, we will cease the surgery and do it a couple of weeks next. But if the bleeding for half, I think maybe half of the cases, the bleeding will stop spontaneously, and at that circumstance, we will continue our life.
So the point is, do you have a special? You have a special technique if you have some blood clots that can affect the field to remove, or, yeah?
Usually the irrigation will clear some of the blood clot, and the rest of the blood clot, if they will influence our manipulation, we will use a grasper for the flexible ureteroscopy to take it out.
Okay.
So that's why.
Okay, I will be back again to our colleagues in Libya. Any further questions? Dr. Raouf, you have more questions?
Thank you, Dr. Farhan. Yes, we have another question regarding this thin parenchyma in the case 2 and case 3. And where there is a hematoma, or if there is a sepsis, he elaborated in the third case of sepsis, where the patient received preoperative antibiotic, and despite of this, she goes in neurosepsis. What his opinion regarding in these cases, if we have a case like this and we suspect there is an infection, we give antibiotic, and we might put a percutaneous drainage and small percutaneous tube, and we proceed with the flexible ureteroscopy, so that we might, in my opinion, we might reduce or almost prevent any sepsis.
Okay.
What I mean?
It's it's a very valid point and very important question. But before jumping to case 2, I will go back again to case 1. Dr. Wang, you mentioned about that you are using ice saline irrigation to reduce the bleeding or to stop the bleeding. Can you explain more what the mechanism of this ice irrigation, or you mean ice or cold saline, you mean, and what's the temperature, what is the amount, for how long you will keep it, and what's the mechanism of this cold saline?
Actually, I don't do the ice irrigation. So I found this solution from one book. So I cannot answer this question very well, because I don't do this myself.
So this is not your personal experience. It's just something you read.
It's not my experience. Okay. It's not my experience.
Yeah, because actually we don't have this practice in our region to use this ice saline, so I don't have experience.
Yes, it's not regularly, I think.
Okay. Okay. One question again: if you have a clear source of bleeding, do you think that laser coagulation can help to control the bleeding?
Sometimes it works, I think, and it will rely on the machine of the laser machine. I think the better machine is.
So what parameters do you prefer to use the laser machine to coagulate? So do you increase the frequency, reduce the power, or which parameters?
I think the power should be large, and frequency should be low to coagulation.
It's close to the fragmentation parameters?
Yes, close to the bleeding tissue, but not don't touch. Fragmentation. Yes, I think the parameter is close to the.
Yeah, but I think as if we have a urothelial tumor, we need to increase the frequency to control the bleeding if you are having, or to ablate a urothelial tumor.
The tumor. Actually, in our center, we don't use the human laser to treat the tumor of the ureter. So, but in my experience, I think the high power and the low frequency is okay for coagulation.
Thank you. I will go back again to the question from Dr. Raouf, and I think it's an important question. For case 2, if you have, this patient with high-grade hydronephrosis and atrophic renal parenchyma, and the stone relatively large, it's 1.5 centimeter. So his concern in such cases, the risk of infection is high, the risk of the kidney is compromised. So he suggested that the main target is to do decompression of the kidney. So you have to relieve the obstruction first by inserting a small PCNL tube, and then come back after 2 weeks so you can manipulate the patient in a better way. What do you think?
Yes, I think the nephrotomy is for this case. I think it's okay. It's good choice. But but this case I cited from the one hospital in one county of our province. So it's not come from our center. If the case this patient goes to my hospital, we will do the drainage first.
Yeah. So it's very clear message, Dr. Raouf. Honestly, I can share with you, early morning today, I got a call from my hospital, almost similar case to this case. And I discussed with my fellow and my residents, so they will go to just to drain the kidney. But usually in our hospital, try first to put a double J stent, which we can get double benefit of that. So we will drain and decompress the system, and the double J will be kept for 1 or 2 weeks, and then it will make the as if ureteroscopy dilatation. So after 2 weeks, you can go to the ureter easily, and you can deal with the stone. So it's very clear point, and Dr. Wang agreed that decompression of such cases is the ideal choice, and whatever through nephrostomy or double J stent, and then you can go for the active stone management 2 weeks later, so the kidney can regain some of its power to avoid the infection, and you can manipulate the stone much easier and to avoid such complications that happened in such a case. Any further questions, Dr. Raouf or our colleagues?
Yes, please.
Dr. Tariq?
Doctor, yes, please.
Yes, Dr. Tariq.
Yes,
go ahead.
Thank you for this nice presentation. My question
Your voice is not clear.
Yeah, regarding the preoperative hemic infestation. do you hear me?
It's
okay now?
interrupted. Try again.
Regarding the uroseptic case.
Yeah.
Uroseptic. Okay.
Do you hear me, please?
Yes, I can hear you.
Yeah. It is. Yeah. Regarding the Escherichia coli, you mentioned the patient have Escherichia coli preoperative. Do you think that the urine should be clear pre-surgery rather than you give antibiotic and the patient still they have Escherichia coli? And my second question, what are in your experience, what are the measures procedure you have to do to avoid the urosepsis?
Sorry, I cannot hear very clearly.
It's not
okay.
clear. So let's start with the second question, which is very important. What are the precautions? Dr.
Yes.
Wang, do you hear me?
Can you speak again?
Okay.
Yes.
So
Now,
the question
now I can
is,
hear.
yeah, what are the main precautions to avoid such sequence of urosepsis? You can summarize.
Yes, precaution.
现在的我们大多数毛刷只能够用在保护鞘的嘛，就是支气管镜到了
LV,
病灶
you're
的
making a lot of noise, LV. Can you mute yourself?
我检请到的插入毛刷，然后当毛刷伸发支气管镜1到2厘米的时候呢，再推出内套管，然后顶上毛刷末端的贴封保护塞。
Someone is talking, LV, from your end.
那个毛刷的主用法，然后再采集标本。 然后依次退回毛刷和内套管，就是说我把毛刷伸出去的时候，刷子肯定是在套管里面的。当我刷完了以后呢，我拿就是我
Can you hear me?
刷子退过来的时候，
I hear you, but someone is talking from
Someone is talking.
I don't know where.
Okay. Okay. Yes, I think to precaution for the uroseptic shock, I have mentioned in my presentation, so there's a lot of precaution, like the urinalysis and the uroculture should be tested routinely, and of course, if the urine culture is positive, the use of antibiotics is necessary, and 7 days to 14 days is better for the antibiotic therapy. And the preoperative drainage, I think it's very necessary for the patient if he has a severe infection. And the secondary surgery. Secondary surgery of fURS after the urethral stent in ready, it also can induce the incidence of the uroseptic shock. But although we do all of this, still some patients will get a uroseptic shock post-operative. I think maybe this will influenced by the gene of the patient or the bacteria, the bacteria in his body is different. Okay.
Dr. Wang, let me to have a small comment here. Let's be fair and not biased to the retrograde intrarenal surgery. In one of your cases, you show that it's a large stone and multiple stones in the pelvis, in the case which went into a sepsis. Can you show us the CT scan? Yeah, go down.
Yeah. Go down.
let me to ask, what is the size of this stone?
Size,
Because
I think it's 1.5 centimeter for this part of the stone.
And the other one?
And the other one, I think it's similar.
Okay. So we can say the stone burden or the stone volume in such a case is larger than 2 centimeters. It can reach, both of them are 3 centimeter stones and associated with high risk of hydronephrosis, high risk of infection. So I think the message here that the selection of case for flexible ureteroscopy should be optimized. So if this case can be for BCNL, I think we can save a lot for the patient, because this case will never end in one stage, because you stayed 1 hour, and I think 1 hour is not enough to keep these patients stone free. So it will be multiple stages, added cost, added burden to the patient, added risk to the infection. So I believe your message is very clear that sometimes we have to select the proper cases to get the best results. Do you agree with me?
Yes, I agree.
Yeah. Dr. Tariq, I think he answered your second question. Can you repeat again your first question? It was not clearly heard from you.
First question was,
We cannot hear
he
you, Dr.
operates the
Tariq. There is
patient,
connection error.
and there is Escherichia coli. He mentioned this in the case, isn't it?
Maybe, I don't know, but do you hear me now? Can I write this?
Go ahead, please.
I would try to write it, but it should be the urine clear sterile pre-surgery, or no?
Okay, Dr. Wang, if you have a patient with white blood cells in urine and the culture is positive, are you treating him to be cleared from infection, or just cover with antibiotic and proceed?
Yes, I will suggest a patient to underwent antibiotic therapy.
Yes.
And we will compare the white blood cell in the urine pre the therapy and after the therapy. And we will do the urine culture again to make sure that the urine is clear or it's better.
Yeah. So the answer is clear, Dr. Tariq, I think, and I think all of us agree that you have to treat the infection to be cleared and to work in a safe environment in a sterile urine. So this is the ideal situation to avoid that risk. Any further questions from other colleagues?
Yes, Dr. Yasser, how are you?
Good, welcome.
I am Dr. Ali Ubaidi from Benghazi, Armenia.
Marhaba.
I want to ask second case with hydronephrosis and upper ureteric stone.
There is echo around you. There are multiple devices are connected.
Okay. Second case with upper ureteric stone, 1.5 centimeter, and severe hydronephrosis with thin parenchyma.
Yes.
And the post-operative complication is urinoma, perinephric urinoma. And there is a small residual stone in the upper ureter. How to manage this complication? By percutaneous drainage or inserting WJ stent or conservative treatment? How to manage if this complication already happened?
Okay. So Dr. Wang, let me to ask few quick questions. In this case, do you think it's only perinephric hematoma or mixed with extravasation? So it is like urinoma.
This case.
Case 2.
Case 2. 他问说有没有尿的时候 I don't think this is urinoma. This is What's your question? So,
is it pure hematoma, so it's only blood, or it can be
yes,
extravasation with
yes,
mixed
only
with
blood,
urine?
only blood.
Only blood. So
only blood.
Our colleague noticed there are still residual stone in the ureter, so it can induce some obstruction. So you prefer to drain this kidney by double J or by nephrostomy tube?
This the post-operative CT scan. We have they have in the well the double J stent in the ureter, and we can see here. This is the double J.
So
But
it's not a residual stone.
It's not a stone. It's not a stone. It's because the hematoma squeezes the pelvis, so the double J stent goes down. It's not a stone.
Do you think that double J stent drainage in such hematoma will be enough, or better to put a nephrostomy tube, because double J can be easily blocked with this massive bleeding?
But this patient, he didn't have the hematuria, so I think the double J is enough. If they have if the hematuria is severe hematuria, I think it will be spotted immediately if the bleeding is severe. So,
okay. Do you think drainage of the perinephric hematoma can help to avoid the compression over the kidney, or it doesn't require?
Drainage, I think it's useful.
Because sometimes this perinephric hematoma can induce some perinephric infection or abscess.
Yes,
so to put a drain, it can help early recovery. Do you agree?
Yes, I agree. I think, and we have met this situation.
But it has the other risk factor that usually the perinephric hematoma making a tamponade and can help to stop the source of the bleeding. So we have to make some balance and evaluate its case by case, if I can keep it without interruption, or if there is a high risk of perinephric infection, so I can put a small drain. So there is no fixed rule. It can be evaluated case by case. Any further questions, my dears?
Sir, can I ask a question?
Yes, yes, please.
I'm Dr. Nashran from Iraq. Just I was wondering about the prophylactic antibiotic that he's using in cases of patients with sterile urine. Will he start prophylactic antibiotic 48 hours before the procedure, as some are doing, or just with induction with anesthesia? And possibly for how long is recommended to be given?
Good. I will explain once more, Dr. Wang. In regular cases, you give prophylactic antibiotic just before the procedure or few days before?
We relate to a situation. If the patient that don't have the infection, we will use the antibiotics 30 minutes before surgery.
So you, because our colleagues colleagues in some hospitals, they have a protocol to start 24-hour, others can start 48 hours prophylactic antibiotic. Do you have the same or not?
No, for the prevention of the preventative infections, we use 30 minutes before the surgery. If the patient have the infection, we have to treat the infection. We will use the antibiotics 40 hours before, even 1 week before surgery.
Okay. So, what's your protocol in post-operative? If straightforward the case, do you give antibiotic or no?
We give the antibiotics for 24 hours to 48 hours regularly.
Okay. So, Dr. Gharib, the question is clear. Answer is clear. Yeah.
Yes, sir. Thank you.
Okay. Any further questions?
Yes.
Yes, Professor
Thank
Farahat.
you very much. For all.
Yes, please.
For all. I ask about the time, ideal time for the procedure.
What time?
About the
How
duration,
long?
maximum duration for the flexible.
Maximum duration. Yes, I have mentioned in my presentation. In our center, the lithotripsy time is the maximum lithotripsy time is 2 hours. If we use the human laser to do the lithotripsy over 2 hours, and the stone still there, we will cease the procedure and do a secondary surgery after a couple of weeks.
Okay. I think we can take one or two more questions because we still have another presentation with a lot of challenging cases and a lot of questions will come up. So any last question, please?
Yes, Professor Farahat.
Yep.
I have one question regarding the urethral injury, the grades, grade 1 and 2 and 3. For grade 1, I think they might put DJ stent or just they leave it. For grade 2 and 3, when you have injury, of course, you have to put the DJ stent. My question is that after removing the DJ stent, what is the schedule of the follow-up just to make sure there is no stricture? Is they have a fixed protocol of doing, say, IVU or any contrast study to see what's happened regarding this grade 2 or 3 injury? When we do IVU and when we decide to do urethroplasty or...
Okay. We usually ask the patient to do the ultrasound or the CT scan after we remove the WJ stent. 1 month and 3 months and 6 months to follow the condition of the structure. IVU is not regular. If they have the we suspect he still has the urethral structure, we will prescribe him to do the CTU.
So this protocol, 1 month, 3 months, 6 months for all grades of injury or only for severe injury? Grade 2 or 3?
I think for the grade 1, I don't think it's necessary to do this protocol. But for grade 2 and grade 3, I think it's necessary.
Okay, so grade 2 and grade 3, you have to follow up the patient, yeah?
Yeah, follow up the patient.
That's great. In this area, if I can just take 1 or 2 minutes to show you one case, can I share my screen, Elvi?
Yes, of course, Dr. Yazid.
Okay. If you see this case, there is a urethral injury. See the injury here. What is the grade of this injury?
It's a grade.
Grade 3.
I think at least grade 2.
It's 2 or 3. I can say 3 because this patient has some, you can see the muscle and you can see the periureteric fat in the injury. And why I am showing this one? One thing is the importance of safety guide wire.
Yes.
which I advise all my colleagues, whatever you are expert, keep always a safety wire. This will save you from a lot of things. And actually, this patient needs a strict follow-up because the incidence of stricture is very high. And I don't have maybe the follow-up CT for this patient. You can see a lot of stone fragments went outside parallel to the ureter. So it can be misleading that if you see the plain X-ray, you can say she has a stone in the mid-ureter, but it's outside the course of the ureter. And I can here to highlight one important point. We discussed that in the last session, that our colleagues in China usually using the axis sheath 12-14. Actually, in our region, we are not going for a large axis sheath. We noticed complication happens with larger sheath. And I quoted this presentation from a previous lecture that showing that the degrees of the benefits of the larger axis sheath, that it gives more better irrigation and reduces the intrarenal pressure. But if you look to the same conclusion from the same publication by Oliver Traxler, showed that 46% of severe injury happens with larger sheath. And I can show you here this image. You can see the difference between the axis sheath and the scope. Yes, larger axis sheath giving you better irrigation, better backflow of fluid, but it gives you a wide space between the axis sheath and the scope. And you can see here, when you come to advance the axis sheath, if it moves while you are working, it's not typically as when you are moving with the obturator, because when you remove the obturator and the scope inside the axis sheath, sometimes you cannot, the edges are sharp. And the other study already done by animals showing that larger axis sheath, it can reduce transient decrease in urethral blood flow. And this especially happens with larger sheaths 12-14 or 14-16. And as you can see here, below 50% reduction. It's transient, but it can compromise the blood supply of the ureter, and it can be a risk factor of stricture. And this also correlated with the size, not only, but also the duration, how long you will keep this axis sheath, large axis sheath inside the ureter. And again, I show you the safety guide wire here, how we're using that one. It saves a lot of time. It goes from outside the sheath, so you can go and the axis sheath will be outside the scope. And also keep fluoroscopy to monitor the introduction of axis sheath, because sometimes you have a resistance, and the resistance increase when you are using a larger one. So using safety guide wire, not routinely using the big axis sheath, and keep monitoring under fluoroscopy. It will help you to avoid such injury of the mucosa, which is really a long-term complication to the patient. And I believe that instead of looking to increase the size of the axis sheath, we are looking to have a smaller size scope that can fit with 10-12 or even smaller. And I believe Bosin and Elvie, all the team from Bosin here, we are expecting the 7.5 French scope that I hope to be available in the market soon. That will help us to with 7.5, we can go for 10-12 or maybe 9-11 axis sheath that can help. I hope I clarified the point of injury, how we have to be careful, the importance of safety wire, the size of the axis sheath, and familiarity with the size of the scope. And if you have in your hand a smaller size, it will be better. I think we discussed the cases very interestingly, and I think we can move to the second lecture. Or any more questions, my colleagues? Dr. Wang, we would like to thank you a lot. And we are looking for the second lecture.
Okay. Could you guys
Elvi, are you here?
Yes, I'm here. I think Dr. Lu has been prepared.
Yes, I am here. Could you hear me?
Most welcome.
Hello?
Hello, we
okay.
hear you.
Okay, let's get started. Okay, here I present the challenging cases. My name is Lu Jieyang, and I'm from the SRRSH hospital. So let's get quickly started. I have 7 cases here to present. Case 1 is about the kidney stone, about 2 to 3 centimeters. Case 2 is about kidney stone grow or twisted on the urethral stent. Case 3 about the infectious stones. Case 4 is a parapelvic cyst with or without stones. Case 5 is a kidney stone within the duplex kidney and the ureter. Case 6 is an obstruction in the ureter. Case 7 is the ureter neoplasm, and also offers 2 complete cases behind these 7 cases. Let's see the case 1 is about the kidney stone about 2 to 3 cm. The guideline recommended the PCNL, as previously Dr. Yasser said, is when we facing the kidney stones larger than about 2 cm. But so the PCNL will cause some severe complications such as bleeding and infection. The flexible uroscopy has become an important surgical option for the upper urinary tract vasculitis. So let's see what kind of patient we select if it can be used for the flexible uroscopy. First is a patient with slightly hyperhidrosis or without the hyperhidrosis, and the patient with the sick renal cortex or the patient with the obesity. These 2 kinds of patients may have the problem of establishing the neutral tract. And so this can be selected for the flexible uroscopy. And the third kind and the fourth kind is the patient with solitary kidney or the chronic kidney disease who are not suitable for the invasive treatment, or the patients with bad general conditions such as the cardiopulmonary insufficient or the coagulopathy diseases. So these 2 kinds of patients will not bear the damage or the harm to the PCNL. So maybe the flexible uroscopy will be a better choice. So, and when we're dealing with these kind of cases, the Holmium laser will be high frequency and low energy, which is beneficial for the stones and to reduce the operation time. And we also recommend the stage operations for the patients with the larger stones. If the patients the stone is bigger, and we thought 2 times or even 3 times is acceptable. And controlling the operation time may be beneficial to reduce the complications. Here we present a patient with a stone about 3 centimeters, around 3 centimeters. And we first, you can see we put a urethral stent at first, and then we do the first surgery. We can see the stones are teared apart, and we do the 3rd surgery, and after do the 2nd surgery, and then we took the KUB. You can see the stones are moving out, and this is the last surgery. We can see all the stones in the kidney are dealt with successfully, I think. And this is one case. We have the 100 cases collected in our hospital, and we separate into 2 groups. First is using the flexoscopy, and the second using the PCNL. We can see the stone-free rate and the operation time. The operation time is less than the PCNL group, and the bleeding volume of the flexoscopy is much lesser than the PCNL group, and the hemoglobin decrease and the CRP increase. These standards are much less than the PCNL group, and the stone-free rate is 92%. It's not, it's quite close to the PCNL group. So if we choose the right patient, it would be helpful and much safer to do the flexible uroscopy. And here is the first case, and we can come to the second case. Is a kidney stone go and twisted on the urethral stent.
Dr. Lee, because cases are many, so I prefer if we can discuss case by case, because maybe at the end we can lost or cannot remember the other case. Do you mind if we can discuss one by one?
I think let me finish first.
Okay.
You can, fine. If you have some questions, you can type them in the chat box, and I will check it later.
Okay, that's fine. Go ahead.
Okay, then let's see. The second case is the kidney stone grew out twisted on the urethral stent. The main cause of this case is because the patients forgot to pull out the stent after 3 months, and they have the stone screws on it. And the stone will adhere to tube in anywhere in the ureter, in the kidney, in the bladder, or in the ureter, happens anywhere. And in some cases, the distal end of the ureter stent will be twisted due to the tight block of the stones, not just a growth on the stent. So how to prevent these cases? First, we need to educate the patients and to pull out the ureter stent, and also ask patients to check the KOBLCC stent after the surgery and after the placing the ureter stent. So I would introduce other methods to handle the challenge cases. First is the ESWL. It will make the stone separate in the kidney, and the urethral stent will be pulled out. But the shortcoming is it could not handle whether the stone is break, and if the stone is larger than the 2 centimeters, the stones the stent cannot be pulled out very easily. And if the stone cannot show on the KOB, it's hard to use the ESWL to shock the stone apart. The second way is to use the PCNL to directly crack the stone so that the urethral stent will be pulled out. But as I mentioned before, the tunnel might be hard to establish due to the placement of the urethral stent, and also the complications is more dangerous. So let's see the detailed procedure in dealing with these challenge cases. First, we use a cytoscope or the urethral scope to remove the stones in the bladder if they have stones in the bladder. Using the laser or the other things, it's all okay. And then using the urethral scope to go back towards the ureter and to see if there's stone screws in the middle of the stent. If they have the stones, using the laser to beat it. And the third one is the most important part. You need to burn apart the urethral stent at the urethral pelvic point. And since the urethral stent had been placed in the ureter for more than 3 months, the condition of the ureter is enough to pass through the urethral scope. And once you burn apart this point, the down part of the urethral stent will be pulled out first. And then just we do the flexible urethral scope. You send in the guide wire to the end and put in the shells. Then you can go as previously we deal with the kidney stones. You hit the stones, and that grows in the stent, and using the pointless basket to pull out the stent. If the stones are hit apart, it's very easy to pull out the stent, and just leave the new stent for 2 to 4 weeks and tell the patient not to forget to pull out again. The advantage of this method is because it's more effective compared to the ESWL, and it's less harm and faster recovery compared to the PCNL. Here's some tips we can offer you when you're dealing with this challenge case. First is although the space in the ureter might be enough for the urethral scope to go inside, it might be necessary to prepare a smaller scope, less than 7.5 Frenches. The point that you separate the urethral stents would be as close as to the pelvic as possible. If the part of the ureter is too long, it might be hard to push the end to the pelvic, and you might need to separate again. So if you pull out all the stents, remind that the urethral stem is symmetry with curves on it. So collect all the stents you pulled out and mix them into one stent, and you can check whether there's some pieces left in the pelvic. And sometimes the urine might be, because sometimes the stents might be corroded by the urines or be teared apart when using the basket. Some urethral stents will twist on the stones very hard, so not easy to pull out, but do not use the force to pull it out. It will harm to the mucosa in the pelvic and the ureter. And this is the second case. Let's go to the third case, is about the kidney stone in the duplex kidney and the ureter. The duplex kidney is a common congenital malfunction of the kidney and the ureter. The incidence of the rate is 1 in 150,000 cases. The pelvis, upper the ureter, and the blood vessels are separated, and they also have their own renal pelvis, ureter, and blood vessels. Duplex kidney and duplex ureter often exist in the same time. So the duplex ureter can be opened in the bladder or ectopic urethra, visit tube, or even the vagina. So you need to be very careful. And the kidney stone is likely to grow in the duplex kidney and the ureter due to its abnormality structures and the slower movement of the urine. The challenge part in this case is to deal with the kidney stone in the kidney and find the right way to see this stone. You can see this case, we can check the IVU, you can see these two duplex kidney and the ureter in this IVP. And the procedure when we're dealing with this challenge case is first, you try to put the different urethral stents into the different kidney, but sometimes you cannot find the right way. It's okay, but at least put one urethral stent into the kidney. And then second, find the divided point in the urethra and go into the right way in the help of the X-ray or CM machine. And send the guide wire and put in the shells to the kidney. And the later is quite easy. Once you finish these 3 steps, you just beat the stones with the laser and put both urethral stents in the both kidney. If you cannot find the stones in the kidney, then try to put the sheets back later, and you can go back and check carefully. You can check this. Here's the tips. The portable CM machine will be helpful in the finding the stone, and try to beat the stone in the smaller pieces or dusting the stones, or you can take all the stones out. The narrow urethra and the slower urine will make the small stone pieces grow up again. So here I provide a video showing that how to deal with these cases. You can first check the CT scan on the right. The stone is at the UPJ point. And previously, we don't recognize it as a duplex kidney and ureter. But after we go inside and we check the pelvic, we can see no stones here. So we just go back and check it carefully. So you can see we move back for quite about 5 centimeters, and you can see another urethra here, and we just switch the tunnel and go right into the right way. Then we go in and we can clearly check this stone here. Okay. So this is the case 3. Now we go and see the case 4 is about the infectious stones. As previously, Dr. Wang introduced a lot. Usually the infectious stones are struvite stones and can be detected by the urine test. And the most patients have the typical signs such as pain in west and fever. And the flexible scope is relatively safer way in dealing with the infectious stones. How to deal with the infectious stones? Here's the steps. First, we will put the urethral stent into the urethra for 2 weeks and using sensitive antibiotics for at least 2 days before the surgery. And it depends on the culture results, we'll decide which kind of antibiotics we will use. And then after 2 weeks placing the urethral stent, we can start the operation, put the shells in the end of the pelvic and make sure that the water reflux is unstopped. The third one is quite important because in the infectious stones, they sometimes have the pus substances at the first at the pelvic area. So we need to put out these pus substances at first, and then we use a laser to beat the stones into pieces and pull them out of the pus. And the most important part, Dr. Wang mentioned, and I mentioned again here, using antibiotics after surgery and inspect the CBC, CRP, and the CX7 PCT within 2 hours. So here's some tips. The infectious stones can be fatal, so control the time of the surgery in less than 16 minutes. And in these cases, do not beat the infectious stones into the dust, and try to take the smaller stones out, because the dusting will make the bacteria more go inside the pelvic and into the blood. So if you meet one patient maybe without symptom, but it's infectious stones, once you put your flexible scope in and see a lot of pus substances in the pelvic, and you realized that you did not use antibiotics for 2 days, and did not even put the urethral stents, you need to stop the surgery right now, because once you started to beat the stones, the infections will be very quickly and into the semia. Here is a video we deal with these infectious stones. You can see this is an endless basket we use in our operations, and we first pull out these pus substances and some smaller stones. And look at this. This is a pus substance. Looks like long yellow things. You may check in your operations. And then we just then after move out the pus substances, we use the laser to beat the stones. The infectious stones are very easy to break, but do not make them into the pieces. You can see we almost use the basket in the whole time. And it checks. This is the pus substance. Okay. Okay, let's go to the case 5, the peripelvic cyst with or without stones. The peripelvic cyst is originated outside the renal sinus and invaded the renal sinus. It's happened in about 3 to 4% in all the renal cysts. If the diameter of the cyst is more than 4 centimeters, peripelvic cysts can produce the compression symptoms in the collecting system and the renal pedicle vessels. Therefore, compared to the other renal cysts, the treatment of the peripelvic cyst should be more active. The traditional treatment will include the ultrasound-guided percutaneous serotherapy and the open surgery or the laparoscopic cyst unproofing. The first way within the percutaneous serotherapy is not suitable in this case because the cyst is closely related to the renal pedicle vessels, and the puncture might be penetrated into the renal pelvis or do damage to the renal vessels, resulting in the hemorrhage and other complications. And the open surgery or laparoscopic surgery might be difficult because the cyst surface looks normal in the outside, and the renal cortex is thick, which is not suitable for the operation. The advantage of the flexible uroscopy in this case is because it's more effective because the cyst wall is thinner from the pelvic side, and which lead to the less harm and less chance of bleeding in the kidney. And also can hit the stones inside or beside the cyst in the kidney. The procedure dealing with this case, first 2 steps is the same as we do in dealing with the normal kidney stones. We put the urethral stents for 2 weeks and put the shells in the end of the pelvic. And the third one is the most important part. You need to identify the wall of the peripelvic cyst. There's a 2 ways to help you to identify this cyst wall. First, you can check the color of the pelvic. The cyst wall looks blue under the flexible ureteroscope. And the second one, you can check the movement by increasing the water flow. Once you increase the water flow, the cyst will have the larger movement under the flow. And if there's normal renal pelvic organization, they do not move. And 4, use the laser to cut the cyst and set the laser at the high frequency and low energy. Or you can use the ceiling laser. Here's some tips. First, you cut the cyst wall in circles, not in a line, and deal with the visible small blood vessels at first. And the second is you can use the enhanced CT before the surgery, and it will be helpful in recognizing the vein near the cyst wall and try to avoid this area. Third one is you put the urethral stent into the cyst in order to drainage the cyst liquid and preventing the recurrence of the cyst. And I also remember if there's a stone in the cyst, you need to pull out the stones completely because the stone left in the cyst may grow up again. Here is a video dealing with the cyst. You can see we first find that it's much bluer in this cyst, and then we find some blood vessels. So we use the laser to deal with the blood vessels first. The whole of the cyst we make on the cyst should not be too much. It's enough for you to move in the scope, and about 2 centimeters at most. I think 1 centimeter would be enough for the cut. Then we can go inside and check the cyst wall and if there's a stone inside the cyst. Okay. Okay, let's come to the case 6. It's the obstruction in the ureter. It's one of the most complicated cases in the ureter because the obstruction can occur anywhere through the ureter. Most of the obstructions are in the UPJ point, and others may due to the congenital and acquired malfunctions. And first, I need to address that is open surgery or the laparoscopic surgery is the standard way in dealing with these obstructions. And this is the advantage of the flexible ureteroscopy in this case. First, it's less harmful and suitable for some patients who cannot bear the open surgery or the laparoscopic surgery. The second is the flexible ureteroscopy is often used in the situation that the distal obstructions appear in the ureter, but it's more complex. This procedure dealing with this case is the first and the most important part is find a safe way to the obstruction point. For cases, if you use the obstruction point at the UPJ point, you can use the ureteroscope to the obstruction point first and put the shells and do as previously we do in dealing with the kidney stones. But if this obstruction is at the distal part, such as the internal segment of the bladder wall, it's very hard to go from the bladder to this part. So you need to use a renal puncture and balloon dilations, just as preparations for the PCNL, and go use the shells from the kidney to the ureter and to the bladder, and make sure the tunnel to the obstruction point, not option, obstruction points, and just use the guide wire and put shells near the obstruction, and use the lasers to hit the stones or cut the obstruction point. And the last one is you need to put at least 2 ureteral stents for at least 2 months and ask the patient to do the routine ultrasound. Like Dr. Wang said, 1 month, 3 months, and 6 months if the hydronephrosis happened after the surgery. First, we can see this case is in the UPJ point, the obstruction. So we can see this very little hole at this area. So we use the laser to burn it. This is a quite simple way when we dealing with the obstruction using the flexible scopy. And then we can see stones. This is a simple case. And another case is about the patient who underwent the bladder cystomy and he put the ureter on the side of the belly or something. And you can see the obstructions here at this point using the and then we do the surgeries from the kidney and from the from the PCNL and from the upside from using the flexible scopy. Here's the very interesting video. You can see here is we use the first we use the PCNL to find the way down to the ureter. And this is the flexible scopy. We find the obstruction point, and luckily we can go pass through a guide wire, and we try to put the guide wire into the obstruction point. And then we use the PCNL scope to see the guide wire from the another side, and we follow the guide wire down to the obstruction point here. You can see in the flexoscopy there's something moving. It's the shells, and we put the shells from the upward. It's the PCNL enlarged shells. Yes, and we can see from the flexoscopy that the PCNL shells put in, and to enlarge the obstruction point. Then we try to pass, and you can see from the PCNL side, we can see the flexoscopy slide. And we try to put the PCNL scope in, pass through this obstruction point. Now we can see we put in a guide wire, and we put the urethral stents here. Here we left 2 urethral stents here. Okay, let's see what's next. After we placed and enlarged the obstruction, there's no obstructions here after the KOB. And here's some tips. First, the laser also can be set in low energy and high frequency. Here is what we see is the 0.5 watts and 20 to 25 hertz. And to avoid the bleeding, you can also use the cesium laser. You can set the energy at 5, or you can just use the instruments such as the PCNL enlarged tubes or shears to deal with the obstruction. And also you can use the thinner scopes less than 7.5 inches to reduce the damage of the urethral mucosa. And it's recommended to remove the stones during the operation. If there are more residual stones or urethral mucosa damage, the urethral stent should be retained for more than 2 months. And if you cannot find any possible ways to find the guide wire, the urethral catheters can be inserted from the bladder and inject the diluted methylate blue. The methylate blue will show a little bit bluish channel, and you can follow this channel. Use the laser to cut the obstruction point. And the 7th case is the urethral neoplasm. In this case, we can introduce first most of the urethral neoplasm are the urethral tumor or the polyps. Sometimes it cannot be detected by the CT scan and would be accidentally found in the flexible uroscopy. And the procedure in dealing with this challenge case, first, you need to judge the size and the shape of the neoplasm. Because if the size of the neoplasm is the pedicle calculated one and it's not so large, you can try to first use the basket to pull out the neoplasm and to get the sample. If the neoplasm has no pedicles or it's too large, use a laser to cut it down and use a basket to get some sample. First, we can see a neoplasm with the pedicles. You can see this neoplasm moved through the patient's breathing. It indicates that this neoplasm had a pedicle, so we can use the basket to pull it out first. Look, it's moving. And we use a basket to pull it. You can see the neoplasm can be pulled out very easily because they have the pickle on it. And then we try to pull out the If this one cannot be pulled out, then we use a laser to burn it. You can see once we burn it in the normal working rate, there's a bleeding. So we adjust to the high frequency and the low energy to stop the bleedings. Look, the water is clear. Okay. Let's see, another case is directly using the, we use the cesium laser to deal with the neoplasm. You can see this is, the neoplasm is around the whole ureter and cannot find that pedicle. So we use the laser to burn it. We can see the stones behind the neoplasm. Here you can see the cilium laser is not so effective in dealing with the kidney stones. Now we move another side of the neoplasm and burn another side. Then we use the basket to pull out the neoplasm. And we deal with the stones with the Holm laser later. Okay, here's the 7 cases, and I will also present several challenge cases. Here is the anatomic abnormal calculus. Look at the stone, it's hidden in the abnormal areas. Here we can see it's hanging from the sky, like, so it's not the usual stone we meet. You should be careful when you see the KOB look like that. We can see how we deal with these cases. And we use the flexible scope and cannot find the stones directly. So how to find the stones? We need to combine with the CT scan and figure out the 3D area of this stone. You can see the stones hidden under the cyst, maybe. And here we cut the cyst wall, and then we found the stones. And then we take all the stones out. Well, another case is renal papillary calculus. The stones is under the renal papillary sometimes, and will be divided by the mucous membrane, and also need to be very careful to find the stones underneath. You can see the stones here, and in the flexible scopy, you can see very little stones outside the in the cyst. But once you beat the renal papillary, you can see larger stones underneath. So you need to be careful and check the CT carefully to assess the volume of the stone and do not miss the stones underneath. Look, there's a stone still beneath Okay. Here is several cases I present here. Let me summarize this case. First is flexible ureteroscope is capable in dealing with some complex cases since it can reach the whole urinary tract and try to use the help of the guide wire and the sheath. And always try to find a safe place to do the procedure. And the different choice of the power frequency can make your procedures more flexible. And always put the urethral stents after surgery if it's possible. Thank you for your listening, and thank you for the post support.
Thank you, Dr. Lou. It's really a very interesting presentation, highly demonstrative, a lot of tips and tricks and thank you for preparing such wonderful cases. Let me to check with our colleagues in Libya if any questions regarding to these cases.
Okay.
Let me to ask you first for the first case.
Okay.
If you can go to the table comparison between the flexible ureteroscopy and BCNL. This is study done in your hospital, yeah?
Yes.
I want to check for the operative time. It's in favor of flexible ureteroscopy. Yes?
Yes.
But this is a single procedure or multiple procedure? Because this is a stone. Yeah.
Sometimes, you know, sometimes we calculated together. In my opinion, for the larger than 2 to 3 cm kidney stones, we usually perform 2 times at the most cases. So it would be added together in the about the operation time.
So if I compare now, I should add the 2 procedure.
Yes.
So I think the operative time for 2 procedure for sure would be more than the BCNL.
Maybe because we calculate the operation time a part of the anesthesia. So just calculate the time begin at the time we started this operation.
So just for my understanding, so 83 minutes, this is the average if I do 2 or 3 procedures?
If you do 2 or 3 procedures, then maybe more than 83 minutes, I think.
Okay. And also the stone-free rate to reach 92%, this is not after, should be divided also after first session, what is the stone-free rate to be a fair comparison between the flexible and BCNL. But I think 92%, this is not after the first one, it's after second or third.
Yeah, it's after second one.
Yeah. And coming back again to the total cost, I think to be in favor of flexible ureteroscopy, it raises a question here because also it's a multiple procedure, and we have to keep in mind that usually we re-stent the patient and then do first procedure and re-stent again and do second procedure. So multiple hospital admission, multiple operative time, and I think the cost, it will be higher for sure than the BCNL. It shouldn't be like that.
Yes, if you do the multiple procedures, the time would be much more than the PCNL. But in some cases, we can deal with kidney stone about 2 cm in about 1 time if the patient and the condition is good. So in the average, might be less.
I agree with you. If you can finish the stone in 1 session, I think it will go in the favor of flexible regarding to the operative time, regarding to the cost, maybe regarding to the stone-free rate. But if we add multiple procedure for large stone up to 3 centimeters, my personal information, we have some cases because I have in my hospital the RoboFlex, so we go for sure for a higher, bigger size stones. And also there are a lot of publication for, if you have the publication from Traxer up to 6 centimeters, but he divided the patient up to 3 and 3 to 6. So the cost and the operative time and stone-free rate in single procedure for large stone is not in the favor of flexible ureteroscopy. So our colleagues in Libya, anyone has a comment for other cases? Or
Professor Yasser.
Yes, please.
Hello.
We hear you.
Yes. Regarding the same case, do you think this thallium lithotripsy have an advantage of reducing the time for the larger stones. Their experience, because they mentioned they're using thallium lasers. Regarding the time, maybe the thallium faster than the holmium, and they can finish the case in 2 hours, even with a larger stone. Actually, we don't have thallium in Libya up till now, but your experience or their experience, does the guidelines will be changed with the thallium lasers?
Dr. Lu, is it clear the question?
Yes, because in our hospital we do not use slim lasers very frequently, and in our instrument, the thallium laser has a very low efficiency in beating the stones. We use the holmium laser. The holmium laser is enough for us, so we do not compare these two lasers together. The thallium lasers are usually to deal with the tumors or the neoplasms and the prostate,
maybe.
Yeah. Yes.
Actually, I want to clarify one thing in this point. I think you are our colleague from Libya talking about the new thallium fiber for stones, and I don't think this one that you have in your hospital, because it's still new in the market. Am I right?
Yes, maybe.
Yeah, because he is talking about the new thallium fiber, a lot of publication coming, a lot of trials are coming that it works better in stone dusting, better than the holmium, and it can go for fine dusting, working faster, minimal residual fragments, and it's promising, but personally, I don't have experience with it. I don't have it yet. But I heard from some colleagues and I saw some recorded surgery. It's really promising, especially in stone retrobulging. Because it reduces even better than the Moses technology in keeping the stone close to the laser, and the fragmentation and dusting can be faster and more efficient. But I believe still we need more evidence to support this initial information and to say which is better and if it will stay longer or not.
Yes.
Any more questions? I'd like to check with you in cases of duplex. Sometimes if duplex system, if you have renal duplex, how you can diagnose it? Usually the routine, we do CT without contrast for stone cases, and not all cases can be detected without contrast, that if this patient has duplex or not. Are you doing routine contrast in all cases, or no?
No, we don't do the routine contrast. As I said, if you happen in the surgeries found this patient might be the duplex ureter and duplex kidney, you can put back your shells and put back and check very carefully from the kidney to the ureter and to the bladder. And it's not the acquired for the routine test, because once you check carefully, you can always find the extra tunnel to the extra ureter.
But the problem that we sometimes facing is that you will go based on the plain CT and you couldn't find the stone. You search everywhere, you couldn't find the stone, and you will be surprised that it's like a negative ureteroscopy. So intraoperative, it's not easy to keep in mind that it is a duplex system if you don't have prior information. And
if you really
I have
cannot,
such a case. I have such a case.
If you really cannot find another tunnel, you can use use the CR machine, and yes, this is quite helpful. And if you actually we do not meet this in these cases, we once you cannot find the another way, you can you can what to say with the help of CR machine, you can find most of the cases, and you can carefully check, and you can with this tool you can check almost all the cases. And I haven't met the cases where I cannot find through the whole ureter and the bladder.
I totally agree with you, and I do confirm that if you couldn't localize the stone, so fluoroscopy or injecting contrast can help you to understand the anatomy of the kidney, to find the location of the stone. And this happens sometimes. It's stone in calyceal diverticulum, as you open the mucosa to find the stone or close the calyx. So sometimes there is a stone, but you cannot find. So fluoroscopy with contrast injection, it will help to detect the stone carefully. So this is a very clear message to everyone.
Yes, that's right.
Professor Yasser.
Yes, please.
Regarding the parapelvic cyst and the stone, which he already showing us, he make a window between the parapelvic cyst and the pelvis, and he attacked the stone, and then he left the DJ stent in the cyst. Actually, this is a procedure where we expecting that some of the fluid will extravasate outside, and he just left the DJ stent. I cannot imagine actually. Is it a well-established way of managing the stone, the parapelvic cyst and the stone, or usually what I know, they are doing it by PCN, percutaneous surgery. I cannot imagine I'm just leaving a stent. A stent may be left in the pelvis just to drain it and enhance healing of the pelvic wall opening. I cannot imagine that he's making a window in the pelvis and the cyst, and he end up by leaving the DJ stent in the cyst.
Dr. Lou, can you explain your experience in that?
Because we put once we make the window in the cyst, and we put the DJ tube inside, and the cyst fluid will follow the stent and pour out through the stent. And you might think the window, just a window of this cyst is too small, but in our cases, it's enough for you for the fluid to come out. And since it shrinks and it has a window outside, it will adhere itself, and it shrink and make it smaller. The recurrence of the cyst, in my opinion, is not so much. Most of the cases we put the stents to drain the water out, and after we pull out the stents, the recurrence is quite low. About 10 to 20% will recover after the surgery. It's quite, and I think it's useful when the patient is reluctant to the laparoscopic and ultrasound guided PCA.
Dr. Lou, actually this case, it raised up multiple questions. As Dr. Raouf said, you now created a window between the cyst and the pelvis, and you kept the double J to keep this window open. So even after removal of double J stent, the urine comes from the pelvis going into the cyst. So you put an open channel between the pelvic calyceal system and a cyst. So this is a point of concern. The second point, we are not familiar to have stones inside cyst. Cyst, usually it's a fluid. To have a stone inside, so we believe this is a closed calyx. So it's a part of pelvic calyceal system, or it's like calyceal diverticulum. And this sometimes we face it frequently. And now when I open this closed calyx with the pelvic calyceal system, there is no harm to open it and to get the stone out and keep it open. So I believe the diagnosis of this case to be a parapelvic cyst, it needs re-evaluation. It's maybe a closed calyx or PCL diverticulum.
Yes,
You agree?
maybe yes, I agree with that.
Yeah.
Yes.
Anything else, Dr. Raouf?
Professor Farahat, regarding the case with the stone and suspected papillary growth, we have seen cases where the stone is impacted in the ureter with the granuloma. How did he make a biopsy before doing yes, enucleations of this growth? Because we see cases like this where the stone is impacted and there is a papilloma or and the other thing that almost when he removed this growth, almost the urethral mucosa is left raw. Regarding what happened to the case in a follow-up? Is there developed structure or?
No, I will let, before Dr. Lu, I go to Dr. Lu. I think it was very clear in the video that it is not just mucosal edema or granuloma. It's clear that it is a lesion, it's a mass, it's a high possibility of urothelial tumor. It's totally different than when we're facing an impacted stone with mucosal edema or granulation tissue around. You can recognize the difference easily between both of them. And what he did, he just took it as an excision biopsy. And it's done very nicely. I believe it has been resected very well, especially the first one with the pedicle. It has been resected very well. And in the second one also, it has been removed nicely. But I want to hear from Dr. Lu, how can you differentiate between just mucosal edema around impacted stone and the urothelial tumors?
I cannot hear clearly. Could you repeat it?
You cannot hear well?
So the question is, how you
I will
said
explain. Our colleagues asking, sometimes they face cases with mucosal fold around the stone.
Yes.
It can be due to impaction or edema, which can be similar to the urothelial tumor.
Yes.
So when to decide to excise or to remove this mucosal fold or lesion, or when consider it as edema and deal with the stone?
Okay. It's not what we need to consider. When I talk about this case, I emphasize that you need to get the sample, and that means once whatever you think it is, it's a neoplasmal cancer or just polyps, you pull out the sample and do the pathologic test after surgery. So you need to get the sample. After the pathological test, if you find it's a tumor, then you need to do another surgery. If you find it's not a tumor, then it's okay. I think you don't have to judge it so seriously in these cases.
Yeah, our colleagues also have a concern about the stenosis or stricture that may happen after excision of the tumor. Do you have such cases?
I do not have these cases because the tumor of the ureter usually happens like the blood urine, and some cases are already tested by the contrast CT scans. These are the single test or the smaller neoplasms happened during the flexible ureteroscopy. So these are have low incidence of the tumor for me. And by the way, your colleagues mentioned that using the laser might do the harm on some bleeding in the ureter. Once you do deal with this challenge case, I said you can use the high frequency and the low energy to make the to make the blood to harm to refund the blood loss, and also you can check the membrane's damage. If the damage is above grade 2, you can put a 2-digit tube and leave it for quite a long time, for more than 2 months, to avoid the obstruction in the later.
Okay. Just a quick comment. You mentioned always when you need to put 2 stents together, there are some special types of stent with like endobilotomy stent with 2 different sizes. If you need to go for a larger size, you don't like it?
Usually, I think we don't have the larger stents first, so we usually put 2 stents together.
Okay. I will come back to the case of uretropelvic junction obstruction.
Okay.
It's what you did by flexible ureteroscopy. It's what's called under one kind of endobilotomy.
What?
Yes, it's like endobilotomy, whatever by laser or by electrocautery or.
Yes, we have the cases by laser, and we tried this all kinds of the instruments first. First, we do lasers at the cases where the obstruction place have the stones, so we can both do the obstruction and the stones together.
Okay. My question at the uretropelvic junction, UBJ. All of us know that UBJ obstruction is not a mechanical obstruction. It's a functional obstruction. It means a dynamic segment. So the pyeloplasty is the ideal choice for such cases. And all literature showing the high efficacy of pyeloplasty, either open or laparoscopic, over than the endoscopic management. And only we reserve the endoscopic management for secondary cases of UBJ, not for primary cases.
Yes,
Are this is the same indication in your hospital?
Yes, it's also when we met the UPJ obstructions, we often use the first we consider the open surgery or the laparoscopic surgeries first.
Okay. So this technique by laser mostly for secondary cases or recurrent cases.
Second option.
That's perfect. Dr. Raouf and other colleagues, any more questions?
Dr. Farhat, please.
I
have thank you, Dr. Low. My question, Dr. Farhat, especially to you, can we share our experience regarding the case of missed WJ stent and stone formed, especially in our country, in an Arab country, actually? We have a lot of cases with missed stone in missed WJ stent, stone formed in upper tract and lower tract or ureter. So what's your experience in this dilemma if you face a case like this, please?
What kind of case? Could you speak a little slowly?
Yeah, he's talking about neglected or forgotten DJ stent. Patient has a double J, and for 1 year he didn't come back to you.
Okay.
Actually, we have patients 7 years.
Yes.
7 years. Okay.
Yeah. Actually, yes. In some of countries in our region, the registry of the patient, as you mentioned in the beginning, how to follow up the patient, how to remind, how to counsel, how to inform him. But actually in Dubai, I can share our experience. We have a registry system, so the patient will be he receive a message when the due time of the stent removal should go. Even I couldn't count on my memory or something. It will go to him automated message to remind him that he should come back for follow up or for DJ stent removal. But I know I was in Egypt before and we don't have that system. So it's really we facing such cases for missed double J stent, complicated with incrustation, complicated with stones. And as Dr. Tariq mentioned, sometimes they come after a couple of years, not only a couple of months, with huge stones in the kidney, in the bladder, even the whole ureter. But the management, as you mentioned, you have multiple choices, either to combine PCNL with cystoscopy, with ureteroscopy, with based on where is the main bulk of the stone and which is the easiest way to can fragment the stone and pull the rest of the double J. I think Dr. Tariq highlighted an important point. If we have a lot of cases in our region, why not that we can collect these cases, but we have to document and we can make a nice publication for that. It's most welcome.
Yes.
Okay, I think in our hospital, the best treatment in these cases is what I introduced here, use the flexible scopy, because the PCNL is too much damage for the patient and the ESW is not quite sure to pull it out. And once you have the kidney stones in the bladder, only PCNL or only ESW cannot hit the stones in the bladder. So you can use the ureteroscopy to or even this, I mentioned that you use a cytoscope to beat the stones first, and then you use the ureteroscope to beat the stones in the ureter. Most of the cases, once you beat these two places, the stents can be pulled out. And in some complex cases, there are stones in the kidney and twisted very hard. Then you need to use the third part to burn apart and hit the stones inside the kidney. And this is I think you can deal with this in one surgery, and you can handle it by the patients, and you can pull out the stents in one surgery. It's I recommend it's the best way in dealing with the cases.
I agree with you, Dr. Lou. It's very helpful. The flexible ureteroscopy is very helpful in such situation, and you can save multiple procedures for the patient. Any further questions? I'm really happy today with this discussion, with these really challenging cases, with understanding of the complication, and better than to understand the complication, to share your experience, how to avoid, how to prevent, how to manage, which is really very useful to everyone. Personally, I got a lot of information. I get a lot of benefit from today's lectures, today's cases, and really appreciate your time, your effort in preparing such wonderful cases and these two lectures. I have nothing to say at the end except that thank you for Hussein, thank you for Professor Lee. Please send my greetings to him, and I wish we will continue collaboration. And thank you for our colleagues from Libya for their time, for their efforts, for their patience, for their experience. They have a lot of experience. I understand. I know many of them, they are experts in the field of endourology. And I hope that we can share some cases from their end in the future. Also, it will be very useful to everyone. Before leaving, I just want to invite our colleagues in Libya, if they have time tonight, that we have. This is our annual conference. Just keep in your agenda. It's 12 to 14. November. Can you see my screen?
Yes, I can see it.
Yeah, so it will be a hybrid. Hopefully that who will be able to visit Dubai, most welcomed. I hope in November it will be a chance to some to attend in Dubai. If not, it will be available in a hybrid mode. Also, one moment. Sharing.
Okay. Thank you, Professor Farhat. Yes, Farhat.
Yeah, tonight we have, if you have time, at 8 p.m. Dubai time. I know it will be late in Libya around 10 p.m. we have a webinar about the stones. It will be about the techniques, PCNL, how I do it, and flexible ureteroscopy, and the combined technique, and medical expulsive therapy with 4 eminent speakers. So if you like to attend the webinar, you are most welcome from 8 p.m. to 9:30 p.m. So this is the final thing from my end. Dr. Lu, do you have any words before closing?
Okay, thank you for the cooperations and thank you for your sharing cases with me. And I also want to thank Dr. Lee and all my teams in the urology of the SRRSH hospital, and have a chance to communicate with the flexible retroscopies. And also thanks Pusin to make this platform for us to communicate. And we sincerely invite you to come to our hospital and go face to face to share experience and see the can know more about the flexible uroscopy. Thank you.
Thank you. Elvi, are you still there?
Yes, I'm here.
So I think we still have the third series of this, which will be next week.
Yes,
do you have confirmed information?
This is what I want to discuss. This is what I want to discuss with Dr. Rolf.
Okay.
Najee. Can we make it next Tuesday, the same time?
Okay, that's fine. Thank you, Pusin. Thank you, all colleagues, and hopefully to see you next week.
Thank you very much.
Thank you.
I'm sorry.
Thank you.
Thank you. Bye.
Thank you. Bye.
بروفيسور ياسر.
ايوه بيه.
بروفيسور ياسر بارك
أنا
الله
معاك
فيك.
يا بيه.
شكرا على البرزنتيشن. السلام. الدكتور رؤوف معك.
اهلا بيك دكتور رؤوف، تشرفنا بيه والله.
الله يسلمك. الله يسلمك دكتور ياسر. لو سمحت الاي دي بتاع الويبنار بتاع ممكن تبعته لنا؟
شور، هبعته لك. انا عايز هحطه على الجروب وتشرفونا ان شاء الله النهارده بالليل. اوكي.
الله يسلمك. شكرا
الله
بروفيسور
يخليك يا
ياسر.
بيه.
شكرا.
تحت امرك تحت امرك، تشرفنا بيك. مع السلامه. مع السلامه.
Thank you very much, doctors. Have a nice day.